So today we'll hear from Heather Adair Rouhani from the WHO on the details of the new estimates, as well as from Sumi Mehta of the Alliance on how and why the estimates have been changing over time. So I'm Julie Ipe. I'm a senior associate here at the Alliance, working on our knowledge management and research efforts, and I'll just be kicking us off today before handing things over to our presenters. A few housekeeping items before we begin. We will be using PowerPoint presentations throughout, so hopefully if you've joined through link, you can see the current slide that's on view. It says, Global Alliance for Clean Cook Soda, that has our logo. If for some reason you can't see that presentation, you can also download it. If you look in the bottom left-hand corner of your screen, there's an icon that looks like a computer monitor. So if you click on that, you should be able to see an attachments tab, and in there you'll see a PowerPoint presentation that you could download and view from your computer and follow along. I also recommend that you make sure that if you are having trouble viewing the presentation, that your link viewer is set to full screen. So I am going to mute attendees throughout the webinar to avoid any background noise or static, but do bear in mind that there will be a Q&A session at the end. You'll also notice that there is an instant messenger function. If you are experiencing difficulties with your audio or accessing the presentations, you're welcome to contact us that way. Do bear in mind that that is visible to everyone. Also, we prefer to keep questions for after the presentations, but if you have a burning one that just can't wait, you can enter it via the IM function and we'll try to answer it. But again, we will have a Q&A session after the presentations where you'll be able to type in your questions for our presenters. So with that, I think we'll go ahead and get started. As I mentioned, today we'll be hearing from Sumi Mehta from the Alliance and Heather Adair Rouhani from the WHO. Sumi is our Director of Programs here at the Alliance, and she has been involved in the global burden of disease from air pollution estimates for some time now. She collaborated with Kirk Smith to produce the first estimates global burden of disease from HAP, and she is also various working groups on calculating the estimates. Heather Adair Rouhani has also been involved in calculating these estimates for some time. The 2002 estimates from IHME, as well as the more recent ones from the WHO, which were just released for 2012. And she is currently a technical director at the WHO. So I think we'll go ahead and start with Sumi, who will give us an overview of why and how the latest estimates differ from earlier ones and how they're changing over time.
Oh, okay, good morning, everyone. Thank you for joining us today. So I just wanted to give a very brief overview, if I could here, in terms of where we are and how and why the estimates are changing. So the first reason for this is really that we now have a lot more health evidence available. We have a very robust evidence base now for chronic lung disease, or COPD, child pneumonias, lung cancer, now both from biomass as well as coal, and also for cataract. In addition, there's been some groundbreaking methodology on exposure response, which actually allows us to combine evidence from the range of major combustion sources of pollution, so outdoor air pollution, passive smoking, household air pollution, as well as active smoking. And what this does is it also provides us with the ability to use indirect evidence from these other combustion risk factors to be able to link household air pollution with cardiovascular disease. Hold on, I'm just going to pause for a second because it seems that some people are having difficulty hearing and others are not. Those of you, I think some people are able to hear, so perhaps those of you who are unable to hear, you may want to just try seeing if you can shift your volume a little bit louder. And hopefully that should do the trick. Of course, if you can't hear me, you probably can't hear me saying that. Maybe we'll just, we can type it out as well. So here, if you see the table on the right, you can basically see a summary that kind of provides an overview in terms of the health evidence, how things have changed from when the first estimates were conducted for the year 2000 and then from 2010, and then the 2012 estimates. And I should also note that there will be also some 2013 estimates that will be coming out from IHME in the relatively near future. But so you can see here how the availability of really robust evidence of the type that's needed for doing these comparative risk assessments has really evolved over time. But I should just note that really since 2010 on, the methods have essentially been the same, and also that from that time on, the burden of disease from household air pollution also includes the burden from ambient or outdoor air pollution, which occurs as a result of household air pollution. So another reason, getting back to this, is that the estimates have also changed because the fact that household air pollution is a major source of outdoor air pollution has also been addressed here. Now, on a global scale, it may not seem like very much. You've got really household emissions contributing around 15% of ambient or outdoor levels, and this translates into around 4 micrograms of fine particulate, which is not a huge amount. But at the same time, it's a substantially greater contribution in some regions, especially those with the highest population-weighted exposure to particulate matter. So in 3 regions, this is anywhere from 7 to 10 micrograms per meter cubed. And in the places, of course, where people have a lot of household air pollution due to solid fuel use, this can be quite large, up to 25 to 30% in India, for example. And you can see here on the map, you get a sense of how this differs by region. At the same time, I think that it's worth knowing that in terms of absolute numbers, the number of people at risk has not really changed as much over time. It continues to be around 3 billion people who are cooking with traditional stoves and fuels on a global scale. And of course, because of population growth in the year 2000, this was around half of the world's population. It's now a little bit less than 40% of the population. But in terms of absolute numbers, the situation really hasn't changed. The other thing that I should note is that there has been a change in the burden of disease from other competing risk factors, and this just gives you an idea here if you see, how things have changed from 1990 to 2010, where there's been a lot of progress made in some of the major risk factors like childhood underweight, breastfeeding, and some of the occupational risks, but in other areas, risks have also increased, as you see here with smoking, with some of the kind of more non-communicable disease-related risk factors of, I would say, where people are better off in terms of the higher blood sugars, BMI, and cholesterol. Household air pollution still remains relatively up there in terms of the top 5 here, but there has been some change in the competing risks. And so then I would just urge you to really look, if you're interested in having more technical information on this, we've just provided you with a list of some of the links here. If you're interested in knowing more about the actual burden of disease calculation methodology, I'm actually very pleased to announce that the really detailed technical methods paper on looking at household air pollution in particular has just been published in Annual Reviews of Public Health. You can look at that as well as some of the other more detailed information. If you want kind of the country-specific estimates, those are available for 2010 from the Institute for Health Metrics and Evaluation, and of course the WHO 2012 estimates are also now available here. And with that, I think I'll turn it over to Heather to give us more details about the most recent estimates that have just been released by WHO. Heather, can you hear us? Would you like to take over now? Actually, we need to figure out who is Heather so that we can unmute her.
Because I can't log on to the webinar.
Hear you. We can hear you very clearly, Heather.
The computer, I'm going to have difficulty in terms of changing slides. So, are my slides the first slide up? Hello?
Yeah. A minute to get your slides up.
Hello?
There, we can hear you. We just need to add your slide. Just a minute, please.
Could everyone just make sure who's calling in that you are muted, please? And so, Heather, we now have your presentation up. And again, for those who are not able to see the presentation via the link feature, you are able to download that in the attachment sections. Again, if you go to that icon that looks like a computer monitor and click on that, you should see a tab with attachments. And you'll see both what Sumi just presented as well as what Heather is going to be presenting on now. So with that, I think I'll turn it over to Heather. Heather, would you like to go ahead?
I'm Heather Adair. I'm the technical officer here at WHO headquarters in Geneva on air quality and health, with a particular focus on indoor air quality, but I also dabble a little bit with outdoor air quality as well. So I'm going to, my presentation is basically about the recent figures that were released as of, the embargo was on 1 a.m. the 25th of March, and they're for 2012. So I'm going to give you kind of an overview of the, so the next slide is the presentation over is the methods, so exposure, mortality, the results, so basically on global and regional level, and how are these results different than previous WHO estimates and maybe the other more recent IHME estimates provided for 2010. And then also moving forward, how WHO is going to continue addressing air quality and health, in particular relation to household air pollution, as well as touch a little bit on what we plan on doing with these disease burden figures moving forward. Next slide, please. So in terms of as I was unable to connect, so I wasn't sure, I didn't hear everything that Sumi said in explanation, so apologies if this is any form of repetition. So a quick background on the methods of exposure. As done previously, these new WHO figures use the household primary solid fuel use as a proxy indicator for exposure to household air pollution. And we don't actually have any information on cook stoves used or the other forms of technologies of burning these fuels for combustion. We rely solely on just the fuel. And this is specifically the primary fuel use. So in many homes, actually, that they may be using a more cleaner fuel, such as LPG, to cook with, and they report primarily using that. They still may be using solid fuels over an open fire or an inefficient stove in the background. So in some sense, these estimates could be considered conservative in many respects. The data that we have for exposure comes from 711 national surveys, which is quite a big jump from the previous estimates provided by WHO. And it comes from we have national surveys from 157 countries, covering 99% of all low and middle income countries. So this is a fairly good representation of what the actual solid fuel use is across the world. And as done by IHME and for the recent GBD 2010 program, we developed the non-parametric and multi-level statistical model here in collaboration with the IHME CRA GBD expert group, and that was applied to these new 700 plus surveys to derive new estimates for 2012. And these are available on our Global Health Observatory at the regional level right now. Is that correct? Also estimates 2012?
No, national.
National is also available for 2012. Next slide, please. So in terms of assessing the disease burden itself, WHO only provides mortality estimates for 2012. We, unlike IHME, in previous WHO estimates, we've only provided mortality. We didn't provide morbidity estimates, and this is largely in part because of currently WHO has only estimated mortality for 2012 and has not been able to do the morbidity estimates as of yet. And the disease outcomes, as similar to IHME, is acute lower respiratory infections, ALRI, and that's in children under 5, chronic obstructive pulmonary disease, lung cancer, and this is from both biomass and coal. Previous WHO estimates only relied on coal, And like the IHME estimates, these are now for lung cancer from both biomass and coal. And this is the big chunk of disease, and these are many reasons why the numbers are much higher than before, and that is because of cardiovascular diseases, including ischemic heart disease and stroke. We have derived below, you can see the relative risks, so we have provided averages here for ALRI, COPD, and lung cancer. So these are the relative risks. So one could interpret a person exposed primarily to solid fuel use for cooking is 2.3 times greater risk for COPD than someone who is using clean fuels in the home. For the ischemic heart disease and stroke, because of the relative risk varies age groups, we can't give an overall relative risk average. And so this is, as Sumi probably mentioned earlier, these are derived using this new integrated exposure response function as done with the IHME estimates and developed across combustion risk factors, ambient air pollution, secondhand smoke, active tobacco smoking, and household air pollution. And as in the other previous estimates, we, as a quick technical feature, we use for all burden of disease estimates, they're derived using the population attributable fraction calculations there on the right, which basically looks at your relative risk in the population exposed. So nothing really new there. Next slide, please. And so in addition to similar what was done to IHME in the 2010 GBD assessment, we also have estimated the household air pollution exposure plus ambient air pollution exposure and how the overlap contributes. So basically, in some areas, a significant fraction of ambient air pollution is caused by household fuel combustion for cooking and heating. But as done in the IHME GBD, WHO has used their updated database on ambient air pollution from cities, and using the new methods of combining satellites and chemical transport models and calibrated with ground level monitoring to derive exposure to ambient air pollution in both urban and rural areas. These estimates were applied, and a fraction of that was taken to estimate the fraction of the ambient air pollution disease burden that can be contributed to the household fuel combustion. So, so this helps. This is where a lot of what was previously in the IHME estimates, we had the 3.5 million plus the 0.5 million. This is the same thing, and we have done that with the new 2012 disease burdens here at WHO. So here's the map of the results for household air pollution exposure in 2012 using those 711 national surveys and the multi-level statistical model to derive. As you can see, as in previous estimates, we see a large concentration of exposure, especially in the sub-Saharan African region, and that in the Southeast Asian region, is particularly India and Bangladesh and what have you. And then we also see quite a heavy the Chinese region as well. Next slide, please. So here, currently WHO is only providing estimates at the regional level for the disease burden. So we've provided here just the exposure here by region. And as you can see, high-income countries, we've assumed all high-income countries, there is no solid fuel use. And the largest region is the WHO AFRA region, with approximately around 78% of all households within these countries using solid fuel use primarily for cooking. Second, as mentioned from this map, we also see that in the Southeast Asia region, as we could see from the map, is also a very high concentrated area with a large fraction of households relying on solid fuel use primarily for cooking. So these numbers, when you sum them up, it comes to 4.3 billion people exposed, or in 2012, or about 42% of the global population. So similar to the IHME numbers of 41%. And the 4.3 is a bit higher, as I'll explain a bit later, due to the underlying mortality estimates are different between WHO and IHME. Next slide, please. So here, this is just another way of capturing what was kind of summarizing the total deaths, again, by region. As you can see, we see a lot in the Southeast Asian region because we have a very high population there, and we also see a lot in the Western Pacific region, the low middle income countries of the Western Pacific region. And although there's a high exposure in sub-Saharan Africa, that's where we see the highest level of exposure, but because of the population density is lower in these regions, the number of deaths attributable to household air pollution is quite a bit lower than in Southeast Asia and the Western Pacific region. Next slide, please. So this is an interesting graph. Instead of saying these absolute numbers, we're looking at the deaths per capita attributable. So this is the deaths per 100,000 people, and you can see again that in Southeast Asian region and the Western Pacific is where we see the highest, and then even in Africa, the level goes up a bit when you're looking at the actual per capita ratios. And then in the world, we see about 61 people per 100,000 people are dying from household air pollution in 2012. Next slide, please. So this is a breakdown by disease, and this is one of the big messages that we need to take across from these new disease burden figures, is that non-communicable diseases is a very, very important outcome related to exposure to household air pollution. And this is also the same for ambient air pollution. And you can see that almost around, I would say about around almost 90% of the disease burden can actually be associated with non-communicable diseases. And this is going to continue to rise in the future as we see a rise in non-communicable diseases across the population. These numbers will continue to increase. And I'd also like to point out, though, here we see that 12% or ALRI deaths, which is still an important outcome for household air pollution exposure, because this still accounts for about 54% of all childhood pneumonia deaths can be attributed to household air pollution exposure, making it the largest environmental risk factor, or risk factor in general for childhood pneumonia deaths. So it's an important and significant fraction of children that are dying still from household air pollution, even though these figures are slightly lower. And it's the underlying mortality figures of acute lower respiratory infections is actually why we see such a strong decrease. It's not because that suddenly less children are dying from childhood pneumonia due to household air pollution. It's because the actual disease rate of childhood pneumonia has been decreasing and declining with interventions in other sectors. Next slide, please. So this is an interesting graph here, and this is something that it's a bit tricky for people to understand, is because we always, in the household air pollution world, we're always attributing that we're saying that women and children are the ones that they suffer the most from household air pollution. And looking at this graph, you wouldn't necessarily think so. And this is where it's tricky. It's actually because of the underlying disease burden and mortality in men is higher than in women, but in women and children. And then for women and versus men, it's women actually have a higher relative risk, but because there's not so many of these women dying from some of these non-communicable diseases, we don't see such a high absolute number of women deaths. And that is a large part because in many parts of these developing countries where household air pollution is an important risk factor, the women are often not, they're not smoking cigarettes a lot, and smoking isn't considered within these underlying estimates. Unlike previous WHO estimates of attributable burden, smoking populations were actually excluded for numbers, but from now on, from the IHME and from the new WHO estimates, smoking population is still considered in the underlying burden estimates, and so that's why we see such higher rates, well, not such high rates, but higher rates of actual absolute number of deaths in men versus women. Next slide, please. So, the famous 7 million deaths global figure. This is the one that's all over the headlines and all over the news. And this is where we're looking at the joint effects of household air pollution and ambient air pollution. And so where did we get the 7 million? And this is where we're looking at combining both the household air pollution with the ambient air pollution and subtracting the overlap of those people that are exposed to both household air pollution and ambient air pollution. And it's because of the way the risk factors are calculated, the joint effect is very difficult to actually estimate it the absolute number that are that can be attributed to just one versus the other. So we've done a rough approximation as done in by IHME to estimate around 7 million deaths globally can be attributed to both household air pollution and ambient air pollution. This way we avoid the double counting of household air pollution and ambient air pollution. And again, as seen in other figures of just household air pollution, we see the largest burden in the Western Pacific region and that of the Southeast Asia region, with still a strong burden within the African region. Next slide, please. So this again is just per capita to help explain, instead of looking at such absolute numbers, it's helpful to look at the relative rates. And again, we see in Southeast Asia and Western Pacific, these numbers are still the highest. And we actually, interesting, in Europe and the low middle incomes of Europe, we see some relatively high numbers in comparison to the joint effects. And then we have in NAFRO, again, is following up. In the world, we get about 100 deaths per 100,000 attributable to both household air pollution and ambient air pollution. So, as somewhat explained throughout my presentation, is that what are the differences between these numbers, between previous WHO estimates of just 2 million to suddenly 4.3 million to household air pollution, and to the 3.5 million to household air pollution, and the 4.3 million that just came, the 3.5 million from IHME and the 4.3 million that came out from WHO 2 days ago. And one of the main issues is the underlying population and mortality estimates. WHO has derives their own burden of disease, mortality rates across the world, and they also derive their own population measures. So this, basically, we're starting from a different denominator, in a sense, than what IHME does and what was previously done by WHO. Another big thing that can account for these sudden soaring numbers from WHO's previous 2 million numbers to the 4.3 million, that's essentially doubling, is the disease outcomes accounting for. Because of the improvements in epidemiological data with this integrated exposure response function, that we can actually derive relative risk for household air pollution for cardiovascular disease, which had not been accounted for previously. So the stroke and ischemic heart disease make up a large fraction of the household air pollution deaths. Do you know by chance 80%? 80% of household air pollution. So it's around 80% of the household air pollution deaths can be attributed to stroke and ischemic heart disease. And then we also need to look at, as mentioned, this idea of the risk estimates. And this is these new methods of actually estimating risk across combustion risk factors, and also using this integrated exposure response function. We have derived estimates using a model developed by Dr. Kalpana Balakrishna for the CRA by the CRA expert group to estimate individual risk, women, men, and children for various at an average concentration of households who are using solid fuels compared to those households that are not. And this is, again, one of the differences, but it's very similar to what was done by the CRA expert group for IHME. Next slide, please. So moving forward, to address the household air pollution issue itself, WHO is ramping up their program on air quality and health. In particular, we're soon, in about next few weeks, we'll be having, we hope to have the WHO Indoor Air Quality Guidelines for household fuel combustion to be launched, which will provide specific performance measurements for various household fuels and technologies to protect health, to give guidance and support to countries to implement effective interventions for improving health and setting the targets that technologies need to reach to ensure and to protect and prevent disease from household air pollution, and to also reduce the contribution of households to ambient air pollution. We're currently developing a global platform on air quality and health. Currently, this is very much focused on ambient air pollution, but which will be used to help derive figures in the future for the household air pollution contribution to ambient air pollution estimates. And further down the road, we hope to actually really integrate the household air pollution exposure with the ambient air pollution exposure on this platform. We held our first meeting back in January with experts from various satellite agencies, remote sensing and these types of things to pull this evidence together to develop and move forward on this platform. WHO also is basically, for over a decade, been tracking household solid fuel use in our database, and we continue to maintain that database and update it on almost an annual basis. And so this will continue to be available to people as needed, and we'll be continuing to estimate the disease burden associated with household air pollution moving forward. And we also were working with other international initiatives on air quality, energy, and health, such as the Climate and Clean Air Coalition, and of course the Global Alliance for Clean Cook Stoves, and the UN Secretary General's Sustainable Energy for All Initiative. We both contribute expertise on how one can protect health from household air pollution, but also contributing to the actual tracking and monitoring of air pollution exposure and disease burden of these various initiatives and how we can protect health. All right. Thank you. And if there's any questions, please pass them on.
Hello, Heather. This is John Lang. Can you hear me?
Yes, I can.
Yes,
Hello.
hi. Is there a plan to bring this up at the World Health Assembly in any kind of a broad event? And if so, could you tell us what the plans are?
Well, the World Health Assembly, for this particular year, we've been working. It's going to be raised as there's efforts are being made to add it to the agenda to be discussed, and there's hopes to actually include a resolution in the 2015 on air quality, the 2015 World Health Assembly on air quality and health. I believe various member states are putting that forward. However, we don't necessarily, as working in WHO, we can't necessarily put these forward, but rather member states have to raise them. But there is some strong interest from various partners and member states to do so moving forward.
Yeah, obviously you don't do the resolutions, but is there any kind of a technical briefing on this that will go on?
We are planning a side event. We're planning a side event on air pollution and health, but it will not only be just on household air pollution, but it'll be on air pollution in general, so it'll include both ambient and household air pollution.
Okay, thanks.
I'll be happy to distribute the details of that side event as it comes closer. If I can pass that on that on their listserv. Is that okay, Sumi?
I don't know. Can you hear me, Heather? That sounds great. Oh, we have a lot of background. Hold on.
Okay.
So we have several questions that came in, and so I thought maybe, there's horrible background. Maybe what we'd like to do is read through these questions so that we can address them. But I just don't know what to do with the sound. Okay, so can everybody hear me now? And I hope there's not too much background. So the first question is whether new estimates include household air pollution from residential heating or only where cooking and heating are combined. And I'm just going to run through these really quick because I know there's a lot of feedback. Somebody else asked how smoking is factored into household air pollution and whether and how that's kind of dealt with in the analysis. Separate out smoking from cooking. And then somebody else asked whether WHO has looked into studying the direct effects of indoor air pollution on reproductive health of women, and if so, what are the facts that are available?
Okay, I'll go ahead and begin with the first question on cooking and heating. The estimates that we're providing here are for cooking strictly only. WHO is currently expanding their household energy database to include heating. I personally have been collecting surveys along with Sophie and collating these on heating, but the data is much less available on heating practices in regards to fuel and technologies used. But we're working with the Alliance and others and World Bank and what have you to enhance national surveys to include heating. But both the relative risk, usage, disease burden estimates, as well as the exposures are for cooking only and excludes heating. And so therefore, this again underestimates probably the household, if you want to call it household energy disease burden, because in many households that may be using LPG solely for cooking, they may be having to rely on something else for heating, such as open fire of using solid fuels. Regarding the smoking, these numbers, these underlying disease burden estimates on which we derive the population attributable fraction calculations, they include the smoking populations. And there are recent studies have actually showed that exposure to, for example, ambient air pollution among smokers versus non-smokers, smokers also see an increased risk of disease from being exposed to just even the small levels of ambient air pollution than just from what they had as an active smoker. So it does include smoking.
I'm sorry, Heather, maybe we just want to clarify that we do look at smoking, but the evidence usually provides smoking adjusted rates so that you can actually look and evaluate for those differences.
Right, but for the relative risk, yes, but for the underlying disease burden, mortality estimates, this includes smoking deaths of smokers. That makes sense?
Yeah, that makes sense.
But indeed, I mean, the interventions to reduce smoking, tobacco smoking, would have an impact on deaths attributable to household air pollution and to ambient air pollution, for example. So you can't necessarily look only at, if we got rid of household air pollution, we'd fix the problem for smokers as well as non-smokers. So, and then in respect to adverse pregnancy outcomes and what WHO is doing, because the level of evidence is not very strong yet, and the level of evidence for adverse pregnancy outcomes is not very strong. We have not calculated relative risks associated with those, and therefore our disease burden estimates do not include things like low birth weight and small for gestational age. However, the evidence base is building, and WHO's consultant, Dr. Nigel Bruce, has helped with a systematic review and meta-analysis, which both the CRA expert group has used and WHO has used to inform their evidence base on adverse pregnancy outcomes in relation to household air pollution.
Yeah, and if I can just add to that, there are also several studies that are currently ongoing who are going into more detail with this issue of adverse pregnancy outcome. There's research that's actually leveraged by Alliance support and funded also by NIH that's looking at this issue in Nigeria as well as in Ghana. There's other evidence in place for Nepal, and a new study that's just been launched in Malawi as well. So I think that evidence base will become much more robust in the next couple of years.
Indeed, we hope so.
Other questions, comments?
Oh, we have one more.
Okay, so there's a question about how we can extract deaths just due to cooking. And I think, Heather, this gets back to it was difficult because you couldn't see the original question, to clarify excluding deaths due to smoking. And I think that we need to distinguish here between the underlying disease burden versus the risks that we're looking for in terms of the risk for smokers versus non-smokers. Heather, do you want to address that a little bit?
It's in the nature of the multifactorial etiology in these population attributable fraction calculations, and that the death one person may have died to smoking, but that person's death may have also been attributed to household air pollution. So this idea that you can't necessarily add these population attributable fraction deaths because your number will exceed 100% of your underlying disease burden. And then, as mentioned before, deriving these risks for our diseases, we do control for smoking populations. So when they derive, for example, the relative risk for COPD, they either control for it in their statistical analysis, deriving the risk, or they only look at non-smoking populations across these epidemiological studies that we combine to get this average relative risk across studies.
Yeah.
Does that explain the question a little better? They answered a little better to the question? Sumi, I'm sorry, it's hard for me not to.
I think that's fine. I mean, I think that it's just that basically we have enough evidence to look at the risk and apply it to the disease burden, which of course includes smokers as well as non-smokers. But the actual health research evidence, the epidemiology actually does take smoking as a risk factor into account, so that you can actually look at it that way. We actually had 3 other questions come in, Heather, that I'm just going to read out to you. One is whether this actually includes wick or kerosene lanterns, or are these not yet able to be incorporated? A second one saying outdoor heating of water is common practice in India, so the ambient air pollution can increase. And isn't this true? And then the third one is wondering whether there will be national level estimates available from WHO anytime in the near future.
Okay, so addressing the wick and kerosene lamps, currently our estimates for burden of disease are limited to only solid fuels. However, in our upcoming guidelines and from recent evidence, we can see that there is concern about kerosene or paraffin used as a cooking fuel in homes, and therefore we haven't accounted for them yet, but perhaps in the future they will be accounted for in terms of the attributable deaths to household air pollution because of the high levels of emissions that are associated with kerosene use in the home. In respect to the water heating and practices in India, WHO does acknowledge that this is an important thing, and this is done across the world. And this is one of the reasons we've actually changed the idea of this risk factor as household air pollution as advised by the expert group, because much of what's created in the home or in and around the home contributes to the ambient air pollution and the exposures within the home and around the home. And this is why we've reframed it as this household air pollution rather than indoor, because what is indoors often leaks outdoors, and what's outdoors often leaks back indoors. So we're trying to reframe the risk to account better for this. And this is something we should actually, as we're moving forward in WHO, as we are collecting more data on heating practice, space heating practices, water heating is something we will consider as well to gather future work to improve the data collection on and perhaps include in future data collection efforts and health impact measurements. And I'm sorry, can you remind me of the national estimates? The national estimates is planned for later this year. I think perhaps in a month or so we'll be releasing the national burden in the coming months of the national burden estimates, as we're country consultations and such are going on to ensure that we have to inform our member states accordingly. So.
Great. Thanks, Heather, for those clarifications. Any other questions from the audience?
Okay, maybe we'll just wait 1 more minute to see if any other questions come in, and then we'll go ahead and close.
Okay, Heather, there's a question coming in saying, do you have data for children under 5 years of age?
Data in terms of mortality estimates, or?
Oh, sorry. I'm sorry. Above, greater than 5 years.
No, we have not derived any attributable death calculations between the age groups of 5 and 25. But this is definitely, and this is in large part due to the evidence base is not strong enough for us to derive relative risks, although we do have mortality estimates. So as the evidence base as more research becomes available, we hope, regarding these populations of 5 years and older, between the 5 and 25-year age range, we hope to eventually include mortality estimates, attributable mortality estimates for this age group. And it is a research need and gap that we hope that the Alliance and other partners will continue to address moving forward.
Great, and we now have a late-breaking question, which Heather, I think you'll love, asking you to please explain the exposure assessment for household air pollution.
The exposure assessment for household air pollution. Okay, well, in terms of the actual the distribution of exposure, we use this proxy of household air pollution, whether for households using primarily using solid fuel use for cooking or not. And if perhaps we derive a national estimate from national surveys of, for example, 76% of households in that country primarily use solid fuels for cooking. That is therefore assumed. Therefore, 76% of the population is therefore assumed to be exposed to household air pollution. And from that, we then apply that fraction to the relative risk. Well, if we are using a binary outcome, for example, for COPD and ALRI in terms of relative risk, we consider that 76% of the population are exposed, and therefore we apply that relative risk to that 76% of the underlying mortality to derive the attributable fraction of the attributable death of that particular outcome to household air pollution. And then for other outcomes such as ischemic heart disease and cardiovascular disease, we use the mean concentration of ambient PM particulate matter 2.5 in a home, and then apply that to the integrated exposure response function for that particular age group and population to derive, again, the population attributable fraction. So there's kind of two methods and streams that we derive these exposures assessments, and therefore derive the relative risk for the underlying, to find the attributable burden. It's a tricky question to answer in one or two sentences. So.
But I would actively encourage those who are interested in more of the technical details to actually go to the annual reviews of public health paper that was recently published, because all of the detailed methodology is well laid out there and is probably much easier to follow than on a webinar.
Most indeed. Good suggestion, Sumi.
Okay. Any other questions? Oh, yeah. So the link to that report is actually, if you looked at the slides that I presented, the last page of those slides actually has the links to all of those, and the one from Annual Reviews of Public Health is there as well. It's in the first presentation. It's also in the briefing note. If you had a look at our briefing note, it's there as well. Okay. Any other questions, comments, thoughts before we wrap up?
Just to say, Sumi, this is Heather. I put my email address at the end of the presentation, so if people do have additional questions moving forward, please feel free to email me, and I will do my best to respond in a timely manner.
Great. So with that, I think we'll go ahead and wrap up. Thank you again, Heather, for an excellent presentation and for providing all those clarifications. And thank you, Sumi, for your presentation as well, and also your answers to the questions. And again, thank you all for joining today and bearing with us through a few technical difficulties. This is a relatively new system for us, so we're still trying to work out some kinks, but we hope you all found the presentations useful today, and stay tuned for some upcoming webinars on additional research that the Alliance has commissioned, but also some of our work in country and also our work on market development. So those will always be announced in our newsletter, and we'll also send as emails as well. So thank you all again for joining, and with that, I think we'll go ahead and close. Thank you.